Hi, my name is Nova Shu, and I will be presenting on our project called Outcomes of Procedural-Based Palliation for Malignant Bowel Obstruction. First, I would like to give a bit of an introduction. Malignant bowel obstructions, otherwise known as MBOs, usually occur at the end of life. Their management is usually palliative. Therefore, we can achieve the symptom palliation through either medical interventions or surgical interventions. However, current guidelines on how to manage malignant bowel obstructions do not exist. Therefore, we hope to characterize the procedural and non-procedural management strategies and their associated outcomes to better elucidate the optimal management of malignant bowel obstructions. Moving on to the methods, we performed a 5-year retrospective review from 2017 to 2022 of patients who were admitted with malignant bowel obstructions due to peritoneal carcinomatosis, which is a late-stage manifestation of many gastrointestinal malignancies. Specifically, we looked at an array of primary malignancies, including colorectal, appendiceal, ovarian, uterine, cervical, gastric, pancreatic, and biliary cancers. Patients were then categorized by MBO treatment into 3 categories. The first category is non-operative, which included patients who were only treated with analgesics, antiemetics, and NG tubes. Procedural, which was the second group, included patients treated with venting gastrostomy and stents. The third group was the surgical group, including patients who underwent bowel resection, diverting ostomy, enteric bypass, or open gastrostomy tube. Our cohort consisted of a total of 210 patients. We also analyzed these patients' demographics, admission factors, inpatient outcomes, and mortality of the cohort. Moving on to the results and the conclusions, we see that patient demographics and admission factors were similar across our 3 groups of patients. We also found that patients who underwent surgery were less likely to be on recent chemotherapy, and they were also less likely to present with a malignant ascites on admission. In addition, patients more often underwent procedural interventions for MBO if they lived greater than 50 miles away or had colonic obstruction. It was interesting to note that patients in the surgical group resulted in more complications at 28% compared to the procedural group at 4.5% and the non-operative group at 3%. The surgical group also had longer hospital stays with an average of 17 days. While most patients who were in the non-operative group were discharged home without needs, surgical patients at discharge required either home health or skilled nursing needs. Looking at mortality, 30-day mortality was lowest in the surgical group at 7% compared to the non-operative group at 27% and the procedural group at 36%. Finally, palliative care consults were obtained in 88% of all patients, and the overall readmission rates were at 58%. In summary, in select patients, surgical interventions for MBO are associated with longer survival. However, there is a cost of higher hospital resources and morbidity. Based on the poor prognosis of many MBO patients, early initiation of multidisciplinary discussions may be a way to help decision-making processes for palliative interventions in the future. Finally, future studies are needed to help further characterize readmission patterns and quality of life measures in patients who have malignant bowel obstructions. Thank you.